Let's get into the hormonal and biochemical regulation of labor. We have a few hormones that are part of the labor process. We start with our purple queen, which is progesterone. So you can remember progesterone starts with P and purple starts with P. So our purple queen is basically the progesterone queen. Progesterone maintains the pregnancy by promoting uterine quiescence. It reduces myometrial excitability. It suppresses prostaglandin activity, it limits gap junction formation, and it reduces expression of contraction-associated proteins. Also, it decreases responsiveness to oxytocin. So, progesterone by itself, by reducing the myometrial contractibility, excitability, suppresses the prostaglandin activity, limits the gap junction formation, reduces expression of the contraction-associated proteins, decreases responsiveness to oxytocin. Through all of these things, labor usually does not begin because serum progesterone suddenly falls. In the earlier studies, people used to think that labor begins because serum progesterone suddenly falls, but actually, there's thought to be a functional progesterone withdrawal. So now we know that this involves this research that involves that there's altered progesterone receptor expression, there is changes in receptor isoforms, there is reduced progesterone signaling within the uterine tissues, and increased dominance of procontractile pathways. So basically, we are altering the progesterone receptor expression. There is a change in receptor isoforms. This reduces progesterone signaling within uterine tissues, and there's increased dominance of procontractile pathways. Therefore, the older statement that progesterone concentration itself simply falls before labor is an oversimplification now. We also have our estrogen hormone. Now, the estrogen promotes labor readiness by increasing oxytocin receptors. It increases prostaglandin production. It increases connexin 43 and gap junctions. It increases myometrial excitability and it favors coordinated contraction. So, estrogen is the complete opposite of our purple queen. Estrogen wants the contraction to happen. Estrogen loves labor. Estrogen wants the baby to come. It increases the oxytocin receptors, it increases prostaglandin production, it increases connexin 43 and gap junctions, it increases myometrial excitability, and it favors coordinated contractions. The balance therefore shifts from progesterone dominant uterine quiescence toward estrogen associated activation. Now we talk about the prostaglandins, the yellow prostaglandins, right? The yellow prostaglandin basically ripen the cervix. The prostaglandins, what are they produced by? The prostaglandins are produced by the decidua, by the chorion, by the amnion, by the myometrium, and by the cervix. So who's producing the prostaglandins? The cervix, the myometrium, the amnion, the chorion, the decidua, everything is producing the cervix, right? The prostaglandins, right? Basically, what do the prostaglandins do? They ripen the cervix, they increase the intracellular calcium, they increase the myometrial contractility, they promote the gap junction formation. This is the complete opposite of what the progesterone we're doing. Prostaglandins are promoting the gap junction formation. They're amplifying the effects of oxytocin. So they're they're pro-activating the oxytocin, right? So the oxytocin itself, can we see the main pink queen? Our main princess is oxytocin. Oxytocin binds to myometrial oxytocin receptors. It activates phospholipase C. It increases intracellular calcium. It strengthens uterine contractions. It stimulates prostaglandin release from decidual and fetal membrane tissues. So I'll repeat that again. Oxytocin binds to myometrial oxytocin receptors. It activates phospholipase C. It increases intracellular calcium. It strengthens the uterine contractions and it stimulates prostaglandin release from decidual and fetal membrane tissues. So oxytocin receptors numbers rise markedly near the term, making the uterus increasingly sensitive to circulating oxytocin. So oxytocin receptor numbers, they rise near the term. They become many, right? Making the uterus increasingly sensitive to circulating oxytocin. Oxytocin is important in maintaining and amplifying established labor, but it is not proven to be the single primary trigger of spontaneous labor. So, oxytocin itself is important in maintaining and amplifying established labor, but it is not proven to be the single primary trigger of spontaneous labor. Now, we have something called as the placental CRH. Okay, so we have the placental corticotropin releasing hormone, right? This comes from the placenta and the fetus. it starts the hormonal cascade for labor, by the way. Okay, so placental corticotropin releasing hormone or CRH rises towards term. It's associated with fetal adrenal activation. It is associated with increased fetal cortisol. It's associated with increased fetal adrenal androgen production and also enhanced placental estrogen production, also increased prostaglandin activity and greater myometrial responsiveness. So, what is the placental corticotropin releasing hormone associated with? It is associated with fetal adrenal activation. It is associated with increased fetal cortisol. There's increased fetal adrenal androgen production. There's enhanced placental estrogen production. Or also there's increased prostaglandin activity, there's greater myometrial responsiveness. So it may function as part of a placental timing mechanism, although it is not considered as the sole initiator of labor. But definitely the CRH is part of initiating the labor. Now there's some fetal contribution, right? The fetal hypothalamic pituitary adrenal axis contributes towards labor through the fetal ACTH. This stimulates the fetal adrenal glands, the fetal adrenal cortisol. This helps to maintain the and mature the fetus lungs, liver, stress response. Also, there's fetal androgen precursors like norepinephrine and epinephrine. They increase placental estrogen production and uterine activity. There's also increased prostaglandin there's increased prostaglandin production also. There's also increased vasopressin. This works like oxytocin. It increases uterine contraction, and there's also nitric oxide. Nitric oxide promotes cervical ripening and smooth muscle relaxation. Okay, and what are the inhibitors of uterine contraction? The prostacyclins, which reduces the uterine contractions, high levels of progesterone. Progesterone keeps the uterus quiescent, and beta 2 adrenergic agonists also relax the uterus. So all of the inhibitors have to take a step back in order for the labor spot to come and take effect. Okay. Now, after this hormonal and biochemical regulation, we move on to the Ferguson reflex, right? For Ferguson reflex, let's look at this picture. The Ferguson reflex, you can remember this as a positive feedback mechanism and also as the fetal ejection reflex, right? It's basically a positive feedback mechanism which leads to the fetal ejection reflex. It helps the fetus to come out, right? This is basically when the fetal presenting part stretches the cervix and upper vagina, and sensory impulses travel to the maternal central nervous system. So the fetal presenting part stretches the cervix and upper vagina, and sensory impulses travel to the maternal CNS, and the maternal posterior pituitary releases oxytocin, right? So what is happening? There's a fetal presenting part. It is stretching the cervix and the upper vagina, and sensory impulses are traveling to the mother's CNS, and that CNS has a posterior pituitary, which basically releases oxytocin. Now, this oxytocin released by the posterior pituitary, what it does is it releases oxytocin, and basically the oxytocin strengthens the uterine contractions. Oxytocin leads to more and more contractions. It's involuntary, right? And stronger contractions produce further cervical stretch. So the more contractions there is, there's more cervical stretch, and further stretch causes additional oxytocin release. It's like a positive feedback mechanism. So the reflex becomes particularly important once labor is already established. Okay. Now let's get on with the characteristics of normal uterine contraction. Uterine contractions are involuntary. They are assessed according to the frequency, duration, strength, resting tone, and coordination. So we assess the uterine contractions, right? We assess them according to their frequency, duration, strength, resting tone, and coordination. Now, frequency. Frequency is expressed as the number of contractions in 10 minutes, and you need to learn this. So, frequency is expressed as the number of contractions in 10 minutes. During established labor, there are commonly approximately 3 to 5 contractions in 10 minutes, right? And then there are 5 or more contractions in 10 minutes, averaged over 30 minutes. And this may constitute uterine tachystole, particularly where associated with induction or augmentation. Let me get back to that. Wait, let's first try to bring this onto our screen. Okay. So can you see that frequency is basically expressed as the number of contractions in 5 or 10 minutes, right? Now, during established, there are commonly approximately only 3 to 5 contractions in 10 minutes. This is normal. Okay. Sometimes you get, what do you get? You get 5 or more contractions in 10 minutes. This is averaged over 30 minutes. And this may constitute uterine tachysystole, particularly when associated with induction or augmentation. Okay. Then we move on to duration. Duration contractions often last approximately 30 to 60 seconds in early labor and then 60 to 90 seconds in more advanced labor. There's normal variation, right? There's no specific abnormality here. This is normal variation. And then we look at the strength of the contraction. External CTG using a dynamometer measures the contraction timing, the approximate duration, and the frequency. It does not reliably measure the true intensity of the contractions. True uterine, true intrauterine pressure requires an intrauterine pressure catheter used only in selected clinical circumstances. Therefore, the text's numerical pressure of 30 to 60 millimeters of mercury should not be treated as a universal normal value or something accurately measured by the CTG. But you can remember that 30 to 60 is a normal value in some texts, 30 to 60 millimeters of mercury. So we saw the frequency. How do we establish the frequency? It's established as a number of contractions in 10 minutes. During established labor, there are commonly approximately only 3 to 5 contractions in 10 minutes. If there are 5 or more contractions in 10 minutes, averaged over 30 minutes, this may constitute uterine tachysystole. Basically, extra contractions are happening, and this is particularly when associated with induction or augmentation of labor. And duration is when you have the contractions that are that often last approximately 30 to 60 seconds in early labor and 60 to 90 seconds in more advanced labor. This is normal variation. And then we have strength. And we use an external CTG using a topodynamometer, which measures the contraction timing. It measures the approximate duration. It also measures the frequency. It does not reliably measure the true intensity of contractions. I'll stop the video here and we'll start with diagnosis of labor in the next video.